Let's see here. Hi, everyone. So Shelley Rogers here from Granite Wellness Centers. And I just wanted to thank everyone for your patience and understanding as we've navigated this new webinar platform. Just a couple things briefly. This series, the Nevada-Placer Opioid Summit, is brought to you by Granite Wellness Centers and partners from Placer and Nevada County and the Placer Nevada Medical Association, and as part of our Granite Wellness's Youth Opioid Response Project. We are about to start session 2 of 4. And I just want to mention a couple of things. The continuing education credits are being provided for CCAP counselors, substance use counselors, for the BRN for nursing and CMEs as well. You will receive your evaluation link after each session. So you should have received it for session 1 for those of you that attended session 1. And at the end of the session, once all sessions are complete, we're going to begin to process your certificates. And so we want to ask you again for your patience. We'll be sending those out within about 6 weeks. Many of you have asked for Corey's slides, and he is going to share them with us. And so the slides and the recordings, the links for those, and how you can access them will be sent as soon as they are available. And lastly, I wanted to let you know that chat is disabled during the webinar, but there is a Q&A option if you look down below at your option buttons. And Corey's going to be addressing any questions that, feel free to type your questions in there and Corey will be addressing them. And that's it for me. Thank you.
Thanks, Shelley. And thanks for everybody for joining during your lunch. Even if you get to eat without visuals, I will hopefully keep you mentally busy while you're chewing. The goal for this one is really to talk through trauma. And by trauma, we're talking about adverse childhood events. And as with the last one, I have no disclosures, nor does anybody else around this. So I don't want to cause anybody any pharmaceutical trauma or anything based on that. But when we look through this, we're gonna describe how trauma affects the developing brain. We're gonna talk about how to really apply that understanding to a person with trauma and what it means behaviorally, and how we can really predict a lot of these behaviors based on the neuroscience. And I want to start with kind of defining, what is trauma, and everybody may define this a touch differently, but ultimately, I'm just going to read it because this is SAMHSA's definition, and trauma results from an event, series of events, or a set of circumstances that is experienced by an individual as physically or emotionally harmful or threatening, that has lasting adverse effects on the individual's functioning and physical, social, emotional, or spiritual well-being. So basically, if it really sucks and scares the crap out of you, it's trauma. That's pretty much how you compress all of that down. And I will say that this is individual trauma, and there are things that are societal traumas and things like that, such as famine and war, that occur where multiple people are experiencing the same event. However, they always experience it through their own lens and their own reality. When we look at what is the response to that traumatic event, many people will have their own response. It's that kind of fight, flight, or flee approach, and we have intense fear, which lives in the lateral bed nuclei of the amygdala. The helplessness feeling that you just feel like you have no capacity to overcome this. Horror is a term that's utilized by a lot of people when asked to deconstruct how they felt about a trauma. And then attachment or detachment. And so you can create a significant attachment disorder in the subset of the population who's experienced trauma. And we identify this especially in war-based trauma, where the individual soldier is experiencing trauma. They become very detached from it, and then carry that detachment back. So as we talk through what's going on with the brain and why, it's important to kind of understand that it's not only what happens, but how we respond to it. And I'll talk a little bit as we get towards the end about some of these subset of people who seem to be able to experience deep, significant trauma, but come out on the other side really unimpacted. And there's some theories around that we can chat about. How often does this happen? Well, child abuse, a report of child abuse happens every 10 seconds in the US. That's a report. So probably every second there is some child or early adolescent being abused. And the children who experience trauma are 59% more likely to be arrested, 28% more likely to be arrested as an adult, and 30% more likely to commit violent crime. So this is not a small issue. This is, as I do my work inside of the prison and jail system, we identify a pretty large subset of the population that wouldn't be there if it were not for early domestic violence and trauma. They simply would have just matriculated through life like a standard, storybook human being and just become who they wanted to be. But all of that was interrupted by that those adverse childhood events and trauma. And as we dig into what happens to the brain in those settings, I think you'll understand a little bit more about why that is. And it is just worth a note that children with disabilities are definitely more likely to experience neglect, which is the most significant form of trauma. And yeah, so there's a question about the impact of attachment in childhood. I'll absolutely get to that because this becomes important because the vast majority of trust and interaction and all of those comes up to attachment disorders, and what we would call personality disorders are generally speaking born out of trauma. So keep in mind when we talk about all of these like dependent personality disorder, antisocial personality disorder, histrionic, behaviors and things like this, those are generally born from the maladaptive neuroscience from trauma, and then the behaviors associated with those were just to compensate for it. And at their core is an attachment disorder, which ultimately is the same disorder that we find with aberrant attachment with substances. So it's all interrelated as we go. If we dig in a little more into the prevalence of this, we have kind of more than 1 in 3 women and more than 1 in 4 men in the United States have experienced sexual assault. So I will say that in the clinic that I ran where we saw pregnant patients with substance use disorder, I had 1 out of the over 400 that we saw that had not experienced sexual trauma. All of the rest of them had. And so we stopped even asking, we stopped doing adverse childhood event screening in this subset of the population because it was always severe and usually centered around physical or sexual trauma or both. 80% of female offenders with mental illness report being physically or sexually abused. The majority of clients served in public mental health and substance use are survivors of trauma. This is stuff that if you work in this space, you just kind of, you know that 75% of men and women in treatment for substance use report trauma histories. Now it's kind of a duh. I mean, we just expect it. We assume it. We try to build trauma-informed systems of care around it because we know that it is just the rule rather than the exception. If we look at the kind of original study that's been an ongoing study for years done by Felitti and Anda down in Southern California, they looked originally at 17,000 participants, and we really looked at how these ACEs, or these adverse childhood events / trauma, really affected the individual's physical, emotional aspects through life. And what does it do? And it's not just about behavior or decision making or whether you're sad or happy, but what does this mean for what we see in another person? And what we recognize is that you have this adverse childhood event. We disrupt the neurodevelopment, which I'll dig into shortly, which turns into the social, emotional, cognitive impairment, which we see in the pieces of attachment, the pieces of how relationship building, being able to stabilize your mood. And when those are all maladapted, at that point, you see a pretty consistent adoption of risky behaviors for health, and whether that's substance use, whether that's high risk behaviors, or all of the above, then you're more likely to do that, which then leads itself to disease, disability, and social problems. And while the peak here, we talk about early death, I would also say massive incarceration. And so those two things really ultimately go hand in hand with these adverse childhood events. You know, as we look at this, 67% of the population has at least one ACE. So most of us have had it at some point or another, one adverse childhood event that we could point to that had a disruptive, issue with us. I think for me, I had two. They were in the same category, but different. So my home life was great. I didn't have any racial trauma. I didn't have any of those things. But when I was in the fifth grade, a friend of mine was hit by a car next to me and killed in a parking lot at a high school football game. That's had lingering kind of effects in a sense, like thinking about stuff. I'll still see that every now and then. I don't think it offers me a significant amount of negativity. And then in high school, I had a friend of mine who was killed in front of me in a car accident, and we were in a car right behind him. And then getting on that scene and being involved in that. So those are the two for me. And I can see where that would create some aberrant behaviors, which probably is what drove me ultimately to EMS, followed by emergency medicine, trying to own that, which we'll see as one of the adaptive techniques there. But as you get above that, then we start to get into trouble. So one is one. One has a potential to create that. If the incident is significant enough, it can create PTSD. So it only takes one significant ACE to actually create the risk for PTSD. So that can be an event-specific trauma that creates post-traumatic stress disorder. It doesn't have to be ongoing. It doesn't have to be cumulative. It can just be a single event that has a component, and I will talk a little bit about where that sits in the brain and why kind of panic comes from that. And then the increased ACE scores correlates with worse health outcomes. And when 1 in 8 people have 4 or more, that means we have a lot of people really at risk for this. And if we look at just the basics of people with 4 or more, then we identify that you have 2.5 times the baseline population risk for COPD, hepatitis, 4.5 times the risk for depression, 12 times the risk for suicidality as compared to those with 0 ACEs. And those are still at least 2 times, 3 times, and 10 times those with 1 ACE. So there is a huge difference between having 1 and having 4. And I want to bring this home by what does that mean? Because one of the conversations we're having about is the impact on addiction, which I don't know, most of you have probably seen the numbers that just came out for 2019 that have been finally accumulated. And it looks like we went up by a lot even before COVID with a significant number of overdoses. And so during COVID, we're going to see a significant increase again in overdoses, both from opioids and now methamphetamine and combined utilization. So I think bringing this back to addiction and what does this mean for addiction is important. So I want to walk through, when we look at patients, just because somebody has a diagnosis of opioid use disorder, alcohol use disorder, or whichever, it doesn't mean that they're the same thing. So treating opioid use disorder in one person can be very different than trying to treat it in another person. And I'm going to walk through how trauma interacts with that piece. So these are patients of mine in the past. And so patient 1, early life trauma, neglect and sexual assault as an adolescent. Patient 2, the parents got divorced, so had one of those, a 1 on the ACE, but really no neglect or assault, had shared custody. And basically the biggest issue was fighting over who had the coolest Christmas gift. It wasn't any overt trauma other than the divorce itself. Patient 1, because of that neglect and early sexual assault, ultimately was isolated from friends, and neglect is the single biggest trauma that can occur to create attachment disorders and having an inability to have a strong attachment to someone, because your brain optimizes for that lack of attachment, and so it's less comfortable to be attached. And we'll dig in a little bit more what that looks like. But isolated from friends. Patient 2, lots of friends, hanging out, goofing off, normal stuff. Patient 1, in order to compensate for kind of that isolation and anxiety that goes along with that continued self-neglect, goes to a drug. And in this case, it was marijuana to help palliate that. Patient 2 tried marijuana once in high school, used a couple times per month in college, but really could take it or leave it, had really no issue with that. Whereas patient one, heavy episodic drinking on top of the marijuana early in high school. And so she was very clear that when she drank to become intoxicated, and had many blackout episodes, and probably based on that interaction had a number of sexual assaults take place during those episodes of blackout, even through high school. And patient two, episodic binge drinking in college. I don't know, but maybe some of you on the phone have been in college and maybe recognize that there was a time period while you were in college where maybe you had one or two nights where you possibly had a couple of more drinks than you thought you might. Just saying it's a good possibility. And so episodic binge drinking in college is 60% of college students at one point or another will meet for a transient alcohol use disorder based on their density of use and maladaptive behaviors that come from that, risk-taking, class-cutting, all of those things that come with it. So not uncommon, usually transient in this population though. Patient one, however, started opioids at 19, did not finish high school, but did not go to college. Patient two finished college. Patient one started heroin at 22. So opioids that she started at 19 were because of wisdom teeth. You know, this, it's not just a made up story. This is a really common story for this population. And this is when I saw her because she had been using heroin now for 6 months and was pregnant with her first kid. Patient two went on to medical school. And then I met this patient after I gave them naloxone in the resident call room after they overdosed on fentanyl. So as we look at these two patients, both of these patients ultimately meet for an opioid use disorder. And we would say, if you were to go to the 60,000 foot view, well, they have opioid use disorder, so we should just add on some medication assisted treatment. We'll stabilize them out, maybe some CBT. It's not that simple. You really have to understand the brain that you're working with. And I would go as far as saying that treating addiction in patient one and patient two equals treating a different brain disease with a final common behavior pattern, but the disease density and complexity in patient one is very different than what you're going to treat in patient two. Patient two is pretty straightforward, you know, and we can talk about the difference for them. We'll come back to these patients when we dig in a little more on addiction in another lecture, but I think it's important to recognize that trauma alone accounts for a significant amount of this pathway in these people. If we go to what happens in those episodes of trauma, so when I saw my friend killed, or when someone was sexually assaulted, or if we have structural trauma. So there's some really interesting emerging data that shows that chronic poverty equals basically ongoing chronic trauma. And we see with this a significant increase in the stress hormones that are released. And the hormones are pretty important because these are the things that help us to regulate really important things like sleep, mood, how we intake food, what we crave for food, how we decide to interact with other people. And all of these things in the stress, fight or flight moment that are continually increasing, you increase this corticotropin releasing hormone and vasopressin, which basically means that we're increasing steroids. So we're creating an immunocompromised person just from trauma. So they're more likely to actually get a disease. And as compared to somebody else, because of that immunocompromised state that high corticotropin releasing hormone creates. In the short term, it's really helpful. In the long term, it suppresses your immune system. It decreases your capability to deal with multiple immune threats at one time. So in like cold and flu season, and not to mention COVID, where we have a disproportionate number of people in certain populations that are susceptible to not only getting, but having mortality rate from this, which also harkens back to one of the other aspects of trauma that we're finding now is in some communities, just being Black is equivalent to ongoing trauma because of the structural racism that exists and the strength in which that exists in certain communities. So as we start to identify why somebody has an increased susceptibility to certain diseases, why somebody has an increased susceptibility to wanting glucose, whether that be through certain foods or drinks or that, we can harken back to these structural aspects of trauma that have to do with poverty and race, and even without other incident-specific trauma, people are being traumatized in those situations on an ongoing basis and causing all of these chemicals to be released at super therapeutic levels, creating maladaptive responses that the body doesn't really know how to react to. It's built for short-term stress to react to that and move on. But we've created systems and places where stress is a constant, and the body has not adapted for that. And because of that, we also get this increased norepinephrine relief from the locus coeruleus. Norepinephrine, adrenaline, as that's pinged off and released from there, we get central awakeness, which means we never get good sleep. Our reticular activating system, which is responsible for sleep-wake cycle, is never allowed to cycle properly. So you're getting light sleep, you're not getting deep sleep, you're getting rebound REMs of nightmares and horrible things that you're thinking about that normally wouldn't occur. And then we also get, just from these hormone releases in chronic stress, a decrease in dopamine from the nucleus accumbens. This is important because, as we've talked about before, dopamine is important in reward. And if you're not able to have the normal release of dopamine, you're less motivated to seek out reward. The lower that dopamine, the harder it is to feel reward from things like filling out paperwork for a job, like finishing a grade level in high school. So these are things that with this ongoing stress that we identify, just the hormones, this is before we start getting into the signaling pathways in the brain, before we start talking about structural changes and all of that like we did last week. Just these basic aspects make a big difference in what somebody looks like in an ongoing fashion. If we go to the picture of the brain that we talked about last time, then when we look here, this is what we went through last time, right? We talked about the prefrontal cortex, which is the part of the brain that's responsible for accumulating, bringing in all the signals and helping with complex decision-making and future thought planning. We have the corpus callosum, which is responsible for the left and right part of the brain, communicating, which is important when we have to make decisions in a multifaceted situation. The nucleus accumbens, which is about reward. The ventral tegmental area, which is its partner in reward. The hypothalamus, which is what's making all those chemicals. Hippocampus for memory. Periaqueductal gray for pain. And amygdala for fear and emotional memory. We talked about that in the last lecture. I'm going to add two structures. I'm going to add the structure of the orbitofrontal cortex. I'll dig in a little bit on this one in a sec, but this is basically the part of the brain that helps us assign value to something. This is the part of the brain that we hold that tells us, oh, that's important for me. Having a relationship with this person is important. Obtaining this thing is important. That innate value that we find. And then is the lateral habenula, which is the part of the brain that is responsible for default behavior under stress. Okay, so again, prefrontal cortex, complex thought and planning, corpus callosum. Right brain person has to still talk to the left part of the brain, so it communicates between the two. The orbital frontal cortex assigns value. The nucleus accumbens is for reward. The hypothalamus is for our hormone stability, as well as the stress hormone release. Ventral tegmental area is for reward as well. Lateral habenula, default behavior under stress. Hippocampus, memory. Periaqueductal gray, pain control and opioid production. And amygdala, this is where fear lives. It's also where the emotional memory lives, but really is the emotional brain as we talk about it. All right, so let's dig in a little more. And a little more on this means when we talk about the hippocampus, it's got some really interesting pieces. So we talked about how in trauma we get this corticotropin releasing hormone that's released, and that decreases the development of dendritic spines and branches. Now remember, we spent a lot of time in the last lecture talking about arborization. And that arborization was about how we have a whole bunch of branches with trees when we start adolescence. And part of the piece that's important is trimming those branches and strengthening the connections between those treetops so that we can have good default behaviors, good learning expectations, good emotional stability. But this decreases the development of dendritic spines and branches, which means it slows down the ability for us to optimize that communication. So when you have trauma and we want to change from all of these branches that are overgrown, you may have some trimming of the branches, but you're not having optimization. So what we're losing is redundancy, but we're not gaining consistency. And that's an important piece. And so that long-term memory allocation is also made more difficult, because where this also becomes important is the hippocampus. In the portion of the hippocampus for long-term memory. And when that occurs, we're not actually having the capability to onboard new memory. And if you look at functional MRI studies about the hippocampus, what you'll find is that people with significant early life trauma have a smaller hard drive. Remember, we talked about that last time. The hippocampus is our hard drive. And so it basically takes away the ability for you to allocate new memories. And that's an important piece. So this is cause and effect. Last time we talked about how in adolescence you can have issues that create it, but here is the cause is trauma. The effect is a smaller hard drive, less long-term memory. The amygdala, again, the emotional brain. This is an interesting one because it interacts with more parts of the brain than any other single area. Even that includes even the prefrontal cortex that sits out there. It communicates with a lot of stuff, but more things communicate with the amygdala. So it really is the relay station of how we emotionally react to the world around us. And the central bed nuclei of this is where emotional memory lives. So we talk about the hippocampus in memory. So the hippocampus is where boring memory lives. You know, this is where I read a book and I got to memorize this, so I got to do 50 flashcards and practice it over and over. It's not exciting me. That's where that memory lives. The central bed nuclei of the amygdala is where emotional memory lives. So if you have, if you get an award, or you score a touchdown, or you score a goal, or you win a Best Actor award in the one-act play in high school, and those are things. The memory of that moment lives in the central bed nuclei of the amygdala. Extreme positive memory. So think back on some of the stuff, even in school, that really stuck with you, and you can easily and quickly recall. It's because it's attached to emotional memory. So the more emotion you can attach to learning, the more likely you are to be able to pull that out with a stimulus and then push that back out into the world. So that's great for positive things. The problem is the central bed nuclei also houses bad emotional memory. That domestic violence situation, that attack, the death of someone else, all of those pieces live there. And the interesting thing is people talk about like EMDR, eye movement desensitization or reprocessing therapy, which basically helps to detach the thinking of your history of trauma and detaching the emotional connection. This is how this works. So this is a really interesting piece. If you look at the central bed, that negative emotional memory lives right there. What sits right next to it? Well, it's the lateral bed, and it's the fear response of the body. So fear comes out of the lateral bed nuclei of the amygdala. If you trigger a memory in that central bed, it is attached to the fear response, that emotional response to that memory. And how you remember that connects directly to that fear. And so anything that triggers it, triggers that fear to the point of panic, which creates PTSD. In a sense that anything that triggers that historical thought or that memory always connects you to the same feeling that you felt at that moment, that feeling of horror, that feeling of helplessness, that feeling, of fear gets re-elicited. Now, EMDR utilizes the optic tract to decrease the connection between the memory and the response. And the reason that seems to work, and this is kind of the way that my theoretical approach to this, is that the optic nerve, where we get a signal that comes in, one of the first places it goes is to the lateral bed nuclei of the amygdala. It pops in, goes there. Think about if you're looking down a dark hallway and you see a shadow. You immediately get fearful until you recognize what it is, and then you decrease. It's because one of the first places that optic nerve tracks to when you see something out of the norm is to the fear center. It's a safety mechanism. So what we're doing is utilizing that fast track to the lateral bed nuclei of the amygdala to use a therapeutic technique to disconnect the memory and the fear. So after you do EMDR, even one therapeutic session with EMDR can actually decouple that. So now you can have someone talk about their sexual assault without having the corresponding full body fear and flop sweat that they get from having to have that conversation. So this part of the amygdala is really important to understand and how it attaches to these pieces. If we look at the orbital frontal cortex, and again, these are the two new structures I want you to think about. The orbital frontal cortex assigns value to reward, and trauma decreases the gonadotropin releasing hormone and mineralocorticoid receptors, making it more sensitive when stimulated. So let's unpack that. If I find value in getting an award at work, then I will work harder. And if I do that consistently, my lateral habenula will turn that into my default behavior. So if I get that reward and I wake up in the morning, my default behavior to stress is to work harder. And you work harder so that you can get that reward because your orbital frontal cortex finds value in it. So that's kind of what it's meant for survival. So what happens when that's kind of hijacked in trauma? So let's think about a high schooler who's at home, and on Thursdays, dad has a union meeting. And after that meeting, he goes out with his buddies. And after every Thursday, he goes out with his buddies, drinks too much, comes home. And if he's in a good mood, you're fine. If he's in a bad mood, somebody's getting beat up and somebody's getting yelled at. Something's getting broken. And usually he's in a bad mood. And so because of that, you have a high schooler who is going to hear that car coming down the street. They're going to hear that garage door open on Thursdays. And that all of a sudden is going to pique that fear response because of that past trauma. And so they're going to find value in hiding. They're going to go to the room. They're going to clean things up. They're going to get all their ducks in a row so that dad doesn't have any reason to get mad. And they're going to find value in that disconnect, that isolation from him. They're not going to want to interact. They don't want to make eye contact. They don't want to be around. Now, when they do that over and over again, and they continue to find value in that, then the lateral habenula will lock that in as your default behavior to conflict. How many of you know, either yourself or friends or patients or colleagues, that the minute that you increase the level of conflict, they completely involute and walk away without thinking about it? It's just a reaction. So you can create that reaction by repeatedly finding value in disconnecting and detaching. And when you find that value in that disconnection and detaching, the lateral habenula makes it your default. So now it's not just associated with when dad comes home on Thursday. It's associated with when you have a complex business meeting, when you have an interaction with somebody who stole from you and you back off and you can't interact with that conflict and it's just better for me to walk away. That type of interaction and that change in the brain, if you optimize for that, then it becomes really difficult for you to actually find value in advocating for yourself. So let's look at this from a different angle. Same situation, high schooler at home. Dad comes home every Thursday, drunk, angry, looking for a fight. Well, maybe you're big enough and strong enough to fight. So when he comes in, he bows up to you, you beat his ass. And he doesn't do that anymore. And every time he comes home and he escalates that behavior and he comes at you and you push back, you start to find value in the higher levels of anger, the higher levels of violence. And so you do that enough that now that becomes your default reaction to conflict. And so instead of it just being on Thursday when dad comes home drunk and you're now standing up for yourself, now somebody takes your parking spot and you get out and you beat them, half to death in a parking lot. And it becomes not a thought process, not a decision matrix, but something that has now been optimally hardwired in your brain as something your body finds value in. It is a reflex. It is not you don't do a pros and cons list of what you're going to do in this situation. It is a reaction, and that reaction is built based on early life trauma and how our body finds the pattern and the most value in dealing with that trauma. So these two parts of the brain are really important. And the scariest part of this is that if you have someone who is finding value in that isolation or hasn't really found what their value is at that point, and they use marijuana or they find alcohol, and all of a sudden they finally feel better and they start finding value in feeling better. Maybe it's smoking a cigarette, any one of those things. Then if you do that long enough, then your default reaction will be to go to that drug or substance every time that you have conflict. How many people have we put on alprazolam who may have had a history of PTSD or just anxious, who every single time any conflict comes up, they reach for that pill? How many people have to go smoke a pack of cigarettes when they have a high conflict situation because that was their default reaction to that situation? It wasn't to deconstruct it, work through it, and problem solve. It was a default to the thing they found the most value in because it had alleviated the symptoms at one point of that anxiety and fear. And so they defaulted from their lateral habenula to be what they find value in, which is the drug. So trauma settles this in, and like it says here, makes it more sensitive. So if you have someone with a significant amount of trauma, the first time that they use a drug, that orbital frontal cortex is going to light way up and be like, yep, this is it. This is the thing that I need to do in conflict because this is what my body feels better doing. So I find high value in it. And then you also go back and you bump that dopamine level in the nucleus accumbens. So you find not only value, but reward. And so this becomes really, really important. If we look at the other couple of parts that I want to talk about as it pertains to trauma is the anterior medial prefrontal cortex. Because this is the part of the brain that really kind of brings all the signals in. And it's supposed to take in what your amygdala is saying, what your nucleus accumbens is saying, what your orbital frontal cortex is saying, what your lateral habenula is saying, and take all those signals, compress all of them into a decision matrix, and then make a decision based on that input. But if all of those inputs are deranged and inappropriate, then it's basically just getting bad information. It also gets less overall input with low dopamine and impaired amygdala. So if you have an impaired amygdala that didn't get a chance to really take your emotion and put it to the Spock part of your brain, the logical problem-solving part of your brain, then what you get is crazy brain overriding Spock brain, and not even talking to Spock brain. And when that occurs, then you also don't have any of the normal dopamine coming in that's going to say, we find reward in solving these problems. And you're just going to default to the older part of the brain, which is the emotional reactant brain, which gets into survival mode rapidly. And depending on how your early life trauma was and how you optimized for it, you may be violent or you may involute and continue to be, in the background and hide to the point of complete disconnection from those around you. The periaqueductal gray plays a lot of roles in this because it makes our own endorphins. And the couple of pieces that I think are really important with the periaqueductal gray is that it modulates aggression and defiant behavior. So the ability to be angry but not be aggressive has to do with your periaqueductal gray spitting out some endorphins to give you a little levity. And it gets better at this as you go through life. Some people have this early and do well. And naturally, what you will do is get to the point where when you escalate and your body feels fear or it feels capacity, then what you see is a spit out of endorphins and allows you to have a moderated amount of aggression that is tailored specifically to the issue that you're dealing with. And the defiant behavior, if you don't have opioids and something feels like it's changed or it's different or you're being challenged, you're less likely to be thoughtful about taking that, being introspective, and you're more likely to just react angry with a defiant behavior or defiant words that go with that. So this trauma also decreases the local endorphins through corticotropin releasing factor mechanism, which becomes important because as you continue to add this trauma, you decrease the production of endorphins overall. And so you end up with less ability to modulate that aggression or defiant behavior. which is why if you talk to a client or a patient or a friend or a family member after they blew up and they come to you 3 minutes later and they're like, I'm so sorry, I can't believe that I even did that. They're generally sincere. And it was a reaction. And it was that their lateral habenula said, this is what we normally do. And their orbital frontal cortex says, yeah, we usually like this. And we find a lot of value in this. And then their periaqueductal gray is like, well, this is fine. We didn't need to make any endorphins, so we're good. I mean, that's the domino effect of what happened. So it's not that, again, that they sat down and the anterior medial prefrontal cortex, is having a cup of, chamomile and a chit chat about how they're going to react with what's going on. It's literally dominoes falling, and they're falling in the wrong direction. And with this less modulatory control, if you take a person and you isolate them from other societal inputs that help them to see other people moderating their behavior so that they can also learn from that and optimize their behavior based on those around them, it doesn't happen because when they isolate, they don't see it. And two, aggression generally begets aggression in a sense of you're going to hang around with people who are more like you over time. And in this pathway from early life trauma, that leads a lot of times to incarceration. And if you think you're going to become less violent in the vast majority of jails or prisons, then you haven't been to jails or prisons. Because at the end of the day, the default there is very specifically the lateral habenula allowing you to rapidly create aggression. The orbital frontal cortex, finds a lot of value in you being hyper aggressive so that you hope you are so aggressive with overwhelming verbal and physical force that no one will ever come back at you. I mean, this happens so often, it's hyperbole in movies now, but this is a reality of the behavior that we see. And when we put somebody in jail or prison, we now solidify that as a default track. And then somehow when we release them, we have this thought in our brain, like, they'll figure it out. They'll be okay. And it just doesn't happen. They recidivate because they blow up in a parking lot and punch somebody in the face because they stole their parking things. Or they decide they don't want to wear a frickin' mask in public, and so they beat up some security guard. This defiant behavior has a neurobiological context. And I think that we have to identify as we're treating patients, what is the context with which their trauma occurred so that we can modify how we approach it. So if we look at all of these signals here, this is the normal brain, right? This is what's supposed to happen. Nucleus accumbens sends out reward signals, a little dopamine, and your medial prefrontal cortex is like, all right, this is pretty cool. I'm happy about this. You get your amygdala sending out, I'm not too fearful about this. And here's the emotional memory I have in context with what this means. The lateral habenula is like, well, in the past, we've done this. Orbital frontal cortex says, we find value in this. This is good. You get a little bit of movement out of your locus ceruleus, and you get a little bit of endorphin out of your periaqueductal gray. And that allows you to react appropriately. There's a lot of inputs. If you have discordant inputs, it defaults to the inputs that have the most. So if you have 3 of these structures that are saying this is what we should do, and 2 that are saying this is what we should do, it will default to what the 3 are saying. So this way, it's kind of majority rules in that setting. And interestingly, you can see this, play out on a functional MRI about what portions light up when and in different situations. So it's pretty interesting. However, when we get to the maladaptive brain and we have low dopamine, which is basically saying there's no reward in this. This is all BS. This is a waste of time. And then we have the amygdala pumping out a huge amount of fear, like, oh, this is terrible. We can't do this. I don't want to do this. And then, I get my lateral habenula saying, well, in the past, we were just kind of like beat somebody up for this. So I don't really know why you're asking me. My orbital frontal cortex is like, yeah, we found value in that. That was awesome. And then all of a sudden you have this periaqueductal gray that's like, screw you guys. I'm not making any more opioids. You're not helping me. And then so you get no help at the amygdala. So it further increases that signal to the medial prefrontal cortex. And then you get this increase in norepinephrine because it's like, well, what do? I get all these things saying different things. How am I going to approach this? And the way to think about it is if I'm a general and I'm about to fight a battle, if I rely on intel for this. So how many troops do I need? What equipment do I need? When do I attack? How do I do this? Where do I go? What you do is you get all of that intelligence. You then take it in, and if you find that one is very discordant from the others, you'll listen to it a little bit, but you generally will look at the other totality of evidence to make a decision, and then you make a decision. And so we're gonna attack at dawn on this day with this equipment, with this many people, and we're gonna flank in this direction based on all the information. Now, what if you're that general and everybody gives you different information and none of it's really accurate? So you're going to be like, well, I'm just going to use some bows and arrows. We're going to attack right in the middle of the day, and we're going to go full frontal assault because apparently they don't have any weapons. There's only 2 of them, and we're going to be fine. And then it's, you know, 1 million plus people in the Army with airplanes and helicopters and tanks. This is what our people are up against when they have significant adverse childhood events. They don't have the informational capability right out of the gates to make what we would call a good decision. We want them to, but at the same time, the signaling that's coming to the medial prefrontal cortex can't be trusted. We don't know what their default was. And until we identify what these are, and we can start to very consistently recognize it, undo it, rewire it, recognize it, undo it, rewire it, recognize it, undo it, rewire it, behavior by behavior and memory by memory, it's really almost impossible to get there. So this gets us to the kind of the, well, what do we mean by trauma-informed care? So recognizing that people have had really all of these destructive effects to their brain over time, we need to make sure we're not re-victimizing them then, that we're not adding to the pile on this. And we're really bad at this in a lot of different ways, whether we are jails, whether we are the justice system, whether we are hospitals, private docs, whatever, the systems are punitive and angry, and we usually re-victimize them. And we start very much with, why did you do that? You know, why did you? So we use this thing called the inter-rater reliability error, meaning that we give all of the onus onto the person actively making a decision rather than recognizing the situation that they're in. And so when we do that, we automatically ascribe intent where they may not have had any intent whatsoever. And until we unpack that, we really can't get to a point where we can help them stabilize and be better. And so, you know, we want to make sure that they feel like they have choices and they have some control, and that they can begin to heal and feel trust and create the reconnections required for attachment. And this needs to be culturally competent, not just like, hey, I took a 2-hour course for my company and I get it. I totally understand Indigenous history now because I sat there for 2 hours and said that we can't say these words. It's not it. I mean, you have to go deeper than that. You have to really make an effort to listen and understands that survival in the context of life experience, cultural background. I mean, that's just a duh moment, but it just doesn't happen most of the time. So when we look at the switch, what it is that what did you do? It should be what happened to you. And really starting from that frame, we want to reduce the barriers. We want to make sure that we're maintaining deep confidentiality. We want to remain client-centered approach, meaning shared decision-making. So if I sit down with a client or a patient and I'm like, hey, this is the literature would say this is the best thing for you, but their answer is, I don't feel comfortable with that. It's like, okay, let's talk through that. Not, well, that's what I'm recommending. You know, you can not follow doctor's orders. You can sign out, you know, against medical advice. I mean, I hear all this stuff. It's just so dehumanizing and frustrating. And you have to embrace the transparency. You have to let them in with what you're doing and what you're talking about and what it is, and build an actual relationship. Now, I don't mean you have to disclose all of your dark secrets with people. There are boundaries. But I will tell you, if you want to be good at what you do and you interact with vulnerable people, specifically those with trauma and addiction, you need to pick the part of you that you're willing to give to them on a regular basis. Because if you don't, and you're still working in that situation, people will take what they need in order to feel safe. And then that will burn you out all day long. And so this starts by definitely not judging someone, not labeling someone as this, that, or the other, but just trying to understand that they don't live in their little 3-foot world. They have a whole group around them that we have to be able to interact with on a regular basis. So the principles of this are basically respect, taking time, rapport, sharing information, sharing control. This is the biggest thing that most of my doctor colleagues have a hard time with, is sharing control piece, respecting boundaries, fostering mutual learning, and demonstrating awareness and knowledge for trauma. just tell them this up front. I started when my pregnant patients would come in on visit 1, we were pretty clear with this. And I would say, look, I just want you to know that pretty much everybody who comes on here has a story that's really uncomfortable to tell. And most of my patients at some point or another have experienced physical assault, sexual trauma, any or all of these things. If those are things that have affected you and you want to talk about, we are happy to do it. I recognize that I may not be the person you want to tell that to. And so because of that, here's another person that you can feel free to talk to. Whoever you feel most comfortable with is who we can tap to have you interact with. And just put it out there on the table. That's visit 1. And you don't have to push them. Don't say, so in your pet, don't start off with the trauma screen right at the beginning. I mean, I just find that for people with significant trauma, that immediately spins them up and can create issues that you have to deal with for a longer period of time. So if we look at empathy, God forbid, we use empathy. You're not alone. And sometimes things just suck. You don't have to always be like, well, let's look at this from the positive angle. Shut up. Nobody cares at that point. I mean, stop trying to be like super positive all the time. I know it's helpful when they're ready, but if their life is in freaking shambles, just sit with that. Just sit with it and help them to sit with it. It's not that we have to fix it. We take on this fixer mentality. They still have to be responsible for fixing it. They just need somebody who recognizes it. And especially if you're coming at it from a different angle than they are. And I will say, like I said in the last one, as a privileged white male doctor who's never experienced structural racism, who's never experienced sexism, I mean, I've had poverty at a point in my life, but never dramatic and overt. I can't tell somebody I get it. I don't get it. I've read about it. I can help them work through it, but don't overstep what you really know. And just because you may be in recovery, I see this all the time, doesn't mean you understand their recovery. So making sure that we don't overstate what we can do or what we know so that somebody can feel and do better after this is a really important aspect of this. So to kind of bring this home, it's, trauma really matters. I mean, it gets that. I mean, if they had really bad a childhood and they have adverse childhood events, it impacts their default behavior in society. It impacts their ability to have a relationship with another person. It impacts their ability to be motivated to do anything. It impacts their ability to contain their emotions in such a way that they're not either completely detached from everybody around them in such an awkward way that nobody wants to chat with them, or they're in the opposite direction where they're over engaging and over physically interactive with people to the point of throat punching some dude in a parking lot because they may have thought that that was their parking space. So the neuroscience is important in this, and recognizing that when we talked last time in adolescence about arborization and the changes and adaptation, we recognized that going from step 1 to a final white matter fast track of behavior takes time. And so the neuroscience is important because once we identify it, you don't just flip a switch. Just recognizing you can't check a box and be like, oh great, we're all good. This is so easy. It's not that. What we have to do is we have to be ready to engage this person, because how we respond to their trauma, how we respond to their behaviors is important. And if we start with a person-focused approach with humility and empathy, and recognizing that some of the default rapid behaviors that they have are not decision-making. It's not the Spock part of their brain making that decision. It is just happening for them. We can begin to build systems that recognize that it's not what you've done, but what has happened to you. And we can bring them along and feel empowered with the decision-making that we need to help them with, to the point at which they feel just as much a part of the process as we do. So with that, I'm happy to answer questions. I mean, I could go on and on about this stuff. Here's references for people that like references. We'll send this out, but but I think it's important that we really chat through this and begin to understand, all of these concepts. So feel free to ask any questions you might have. So I will, while we're waiting for any other questions to come in, just push on the trauma impact of attachment. So attachment theory is very much the theory that looks at the vast majority of the ways that people deal with the world, specifically includes how strongly or how weakly they attach to other humans or other groups of people or to behaviors. And so the best way to think about this is if somebody goes to, is in a dual parent household, they've had to learn to attach to two different people who love them. And with that, they will have a balanced attachment. And that balanced attachment allows for someone to not over-attach to one parent as compared to the other, and allow them to pivot back and forth and modulate their behavior / code switch in order to interact with them optimally, which sets them up to be able to do that with a group dynamic and then couple later if that's what they choose. So to identify someone who they can have that same interaction with and that same response. Some of that behavior is modeled by watching it happen, and some of that behavior is learned just on our own interactions as it goes through. So when we look at attachment, as far as if somebody, let's say somebody's kid is goes to foster care, then what you never do is you never get a strong enough attachment, because you're from place to place to place, and so your optimal is to not be attached, and so you have an attachment disorder of never being able to, or not never, but at least not without a significant amount of work, being able to appropriately attach to another person. And I mean, we could dig into this concept for a long time. In fact, attachment theory, if you're ever going to read something about human behavior, read a lot about attachment theory, because it's important. The EMDR and how it separates. EMDR is really interesting, and this is my neurological theory. I haven't seen anybody write this, but when I look at what happens in the tracks and the methodologies that are employed within EMDR, it really does interact in the fast pathway as compared to where fear lives, and how that fear literally, when I say literal, I'm not saying it literal like most people say, not like on the news stations where they're like literally, and it's not literal. Literally, you have a track, a neurological connection and track between the portions of the medial bed, nuclei of the amygdala, and the lateral bed that have to do with emotional memory, and then the fear response associated with that emotional memory. And so because of that, what we can do is have somebody think about what happened and look visually at another stimulus. And whether that's a light or a pen or whichever modality you use, now what you're doing is imprinting this visual memory onto that emotion. So no more are you going to have that memory that turns on the fear. It'll just kind of disconnect it from there. And so that's what we're seeing with that. This one talks about schizophrenia and the neuroscience of the developing brain. Are there correlations between schizophrenia, bipolar, and trauma? There seems to be for bipolar 2 disorder, but not as much for bipolar 1 that we can identify. Schizophrenia, yes, but it needs to be neglect. So that's the only one that seems to have, that I can identify, a direct correlative pathway between somebody being genetically predisposed for schizophrenia and then having that neglect occur, which again decreases dopamine, decreases the chances for arborization to occur, and then you have too much branching and interaction where one side of the brain doesn't know what the other side is saying, and they can't tell the difference between real and not real. And so that's a good question. If neglect is subjective, what's the parameters look like? So basically neglect, and the way in which we look at it to create pathology, is the inability to obtain effective stimulus from another thing in a timely manner when you need it. So the biggest piece, obviously things as extreme as isolation. Some kids will need more attention than others in order for them to not feel neglected. So some kid may have two parents that work two jobs and is a latchkey kid and pops home, grandma sits in a room, doesn't get anything, and that kid is neglected. Some kids may not need that much attachment, that much interaction to feel comfortable. So it's the neglect at its most subjective, is the amount of connection that they need in order to feel safe and cared for. And that's it. I mean, it comes back down to the research around the wire monkey mommy versus the carpet monkey mommy back in the 50s and 60s. Yeah, bipolar disorder, bipolar 2, we talked about. So bipolar 2 is hypomanic with associated major depressive disorder and a different cycling. It's a gross oversimplification, but that's the general concept, as compared to bipolar 1, which is the full extreme of behavior, where you can go to mania, and there are more instances of psychotic features and things like that that go with it. Again, that's its own deep dive, but that's the general concept with that. And trauma, I can't find any literature that pushes trauma into the link of bipolar 1, but I can find a connection with bipolar 2. Legal practitioners use techniques or approaches to best work with trauma-affected persons. The biggest thing is to let them, the biggest thing is to make sure that they feel like somebody has their back, that somebody is advocating. So many times they feel like they're powerless in that system, and it's no different than the trauma occurring, because they feel like they have no say, they have no input, they don't know what's going on. And so the best thing that you can do is make them be a part of some of the decision making that comes up and not be so rote about it. And that becomes important as you go. And in both the accused as well as the victims. So for the victims, you can reconcile some of this by walking through, not by putting them on the stand and walking through the trauma. By the way, that locks it into the central bed nuclei of the amygdala and almost fully imprints it now twice for that. But having them see a trauma behavioral therapist prior to having to do depositions and prior to that, so that they can maybe gain some objective thoughts about this, which generally speaking would mean that they have the somebody doing things like EMDR or even cognitive behavioral therapeutic inputs to really help with this piece prior to having the victim have to be re-victimized in that setting. And the person accused, not that it means anything on sentencing, or it may, but I think also recognizing that generally what drove them to that criminogenic behavior lives in their childhood. It's not like it's not their fault. I mean, they still committed that crime, and we still have to have, safety thought about. But at the end of the day, most people aren't born bad like that. I have to think, that Nietzsche was probably wrong and Locke was right. And I'm hoping that is the case. That Nietzsche would say that we are born bad and have to learn to be good. And Locke would say we are born good and only learn the behaviors to be bad. And there's probably a little truth to both of those, but I have to live a little more on the side of Locke in order to wake up every day. So with that, I'll be done. And if any other questions come in, that'd be great. Otherwise, thank you everybody for staying on, and I look forward to next week.
Thank you so much, Corey. I just wanted to, in closing, thank you for that fascinating information. And I just want to let everybody know, again, this is brought to you through a partnership with Granite Wellness Centers, and it's part of the Youth Opioid Response Project. There are other resources available that, as part of the Youth Opioid Response Project, like the Family Recovery Education Series for anyone who's interested in learning more about addiction and recovery and the different options for families dealing with addiction. And so I encourage you to visit Granite Wellness Center, or granitewellness.org, the website, or Granite Wellness Center's Facebook page to learn about more events, activities, services, and resources. There are also resource lists available on the website. So thank you everybody for joining. We hope we see you all again next week, and let us know if you have any questions. Reach out to us. Thank you.